So in our last few minutes, I want to steer away from the type of disease that you and I are often treating, which is clearly obstructive coronary artery disease, and go into this sort of abyss of microvascular disease and the potential of this. So some studies show that up to 40 to 50% of patients with angina with no obstructive coronary artery disease actually have microvascular disease. And there is emerging evidence that the coronary sinus reducer doesn't really care if your ischemia is in the epicardial or microvasculature, and that this could be a therapy for those patients. What's your thoughts on that, and what potential impact do you think that this could have in the field for this really difficult to treat patient population?
I think that that's probably the most exciting development in this therapy. So I think Amir Lehrman's paper is probably the one that is the, leading to the charge in terms of understanding how this could work. So not only describing a much larger patient population to treat, but maybe even getting at exactly what this thing is doing mechanistically to help treat angina. So, his paper shows some compelling evidence that for patients with microvascular dysfunction, whether it be endothelial dependent or independent dysfunction, that a coronary sinus reducer can effectively correct that dysfunction in a way that helps patients feel better and is objectively measurable in the cath lab, which is fascinating because this is sort of like getting at understanding what it is that this device is actually doing and identifying a much larger population of patients that could be treated.
Yeah, it's the other major study to talk about in that context is the ORBITA-COSMIC study by Rash Alami, and that was published in The Lancet. So this was a proof of concept, double-blind, randomized, placebo-controlled trial. It was just 51 patients, but that was done in the UK for patients with refractory angina, class 3 or 4 symptoms, fully optimized medically, previously revascularized. And they found that using in a sham study, with a very carefully controlled measurement of angina using an online mobile app, that the coronary sinus reducer reduced daily angina episodes by almost 40%, with almost the probability of benefit being almost 100%, which is amazing. But they didn't find an improvement in stress myocardial blood flow.
Which was their primary endpoint, right?
Right. And so it's really interesting to me that either we don't have the tools that are sensitive enough to be able to pick up whatever changes are being done by the coronary sinus reducer, or whatever's happening is happening on the ultrastructural or microstructural level that we're unlikely to be able to pick up.
Yeah, certainly below the segmental myocardial segment, the measurement units for an MRI don't seem to be sensitive enough to understand, because they did describe this redistribution of blood flow in ischemic zones with a ratio of subendocardial to epicardial flow improving, right? So could that be part of it? But this seems to be beyond the sensitivity of the MRI to really measure in an objective way.
How much does that bother you? For you to really put this on the shelf, do you need a mechanistic outcome, or are you okay with the hydralazine approach and say, well, it seems to drop blood pressure some, I don't know how, but I don't really care?
Yeah, I think I'm somewhere in between, right? We all take care of these patients where you've thrown the kitchen sink at them and they're still having angina. So this is something that's relatively low risk and uncomplicated that you can offer them. So certainly it's compelling in that way. But having some mechanistic understanding of what this does certainly helps to make it an easier pill to swallow, right?
So tell me, what's the future of the coronary sinus reducer in 5 years? The trial's done, it's positive, shows exercise tolerance testing is improved. We figure out some more mechanistic data. Where do you see this in clinical practice? Is it a procedure that's done every day? Is it a procedure that's done every week?
I think that this is going to be a regular part of our treatment algorithm for patients with angina that's refractory to medical therapy. So patients that have symptoms that break through good medical therapy are going to be sent to the cath lab. We're going to determine what the revascularization strategy should be. And for the patients that are revascularized or cannot be revascularized, this is going to be part of their algorithm for how to treat them.